Thank you. It's an honor on behalf of the COMPASS investigators to present the results of our trial. The COMPASS trial, a prospective multicenter double-blind study assessing whole blood for the detection of obstructive coronary disease in symptomatic patients referred for myocardial perfusion imaging. In other words, can we develop a blood test for coronary artery disease? We have a challenge and an opportunity among those patients referred for elective cardiac catheterization in the United States based on NCDR data that the patients who come in without known coronary disease for an elective procedure, only 38% actually have coronary disease on the angiogram. So the opportunity is how can we increase that yield for a test that has significant cost and at times complications. Inflammation certainly plays a substantial role in atherosclerosis development, and we've seen that scores are observed change in diseased arterial wall samples. As well in other diseases, the discovery occurred in a population of approximately 300 patients with obstructive coronary disease in the Kathjen and Seberg cohorts. And then it was evaluated in an algorithm development in the first part of the PREDICT trial published last year. In 526 patients, the score predicted obstructive disease with an ROC of 0.7 and added incremental information beyond clinical risk factors. Also, the score is proportional to maximum percent coronary stenosis. A little bit about the test itself. Genes are upregulated and downregulated among the leukocytes, and in fact genes were used, grouped into gene terms. For example, the one in the upper left is a term in which their genes are upregulated related to apoptosis and inflammatory signaling response. Other gene terms are downregulated in response to inflammation in the leukocyte family. These are then normalized based on 3 normalization genes to come up with a score of each of the gene terms weighted, and then this test is adjusted based on age and gender. Looking at our study design, we looked at 537 patients who came into the physician's office with chest pain, and they were being referred for perfusion imaging. The test was exercise or pharmacologic, and in these 531 patients, a blood sample was obtained. They then went on to their microperfusion study. Among those who had a positive perfusion study for ischemia, they generally went to cath. Those with a negative perfusion study went in this study to coronary CT angiography or to catheterization. Among those patients who had all 3, those who had a stress nuclear test and score and a cath or CTA totaled 431. Looking at the cath and CTA was done very carefully with the core lab evaluation. The studies were read on-site as well as with a core lab, the cath core lab being the Cardiovascular Research Foundation, and the CT core lab led by Dr. Salad Voros. Looking at the on-site reads are typically 15 to 20% greater for a stenosis than the core lab read, and that was the same whether it was the core lab for the CTA or the core lab for the cardiac cath using QCA. As I said, all patients also went on to perfusion imaging, and that was read on-site initially and then later in a core lab evaluation. The pre-specified analysis plan called for the primary endpoint being an ROC analysis of the score. Secondary pre-specified endpoints were the score versus site read perfusion imaging, as well as classification of angina type by Diamond and Forrester, and the physician evaluating the test, the patient at the time of the stress test, in terms of what they thought their chance of coronary disease was, as well as the sensitivity, specificity, and the predictive value of the score using a pre-specified threshold of 15, with the score being 1 to 40, for example. We defined a case, that is a coronary disease case, as a patient who had 50% stenosis based on core lab CTA or core lab cath. And again, that would correspond to about a 65 to 70% stenosis on-site read for a cardiac cath, for example. 431 patients had all of these tests. The group is shown up here, the type of patients. Average age was 56. They were non-diabetic. The test is designed in non-diabetics. Their angina type was most commonly atypical angina. As I said, patients went on to either MPI that was positive or negative. Those who went on to a positive MPI, there were 48. The majority of those went on to cath. Some went to CTA, and then 3 went to cath following that, to yield 17 cases among those who had a positive perfusion scan. On the upper scale up here, those who had a negative perfusion study, 383 patients, the vast majority went to CTA, some went to cath, and among those patients, it turns out that 46 also had obstructive disease measured by the 50% criteria. The primary endpoint, as I said, was the ROC analysis, and this is shown here in this black line, looking at the score with a substantial ROC of 0.79. Secondary endpoints including comparing the score in this population to site read MPI, 0.59, and core lab, incrementally better at 0.63. It was also compared to the evaluation using clinical criteria, that is the Diamond and Forrester characteristic was 0.69, and the cardiologist evaluation of whether the patient had disease or not, again lower at 0.67. All these differences are statistically significant. Looking at the test itself, it's a linear test in this range here. On this axis we have the score increasing. Here's the increasing chance of likelihood of coronary disease. The flat part of the curve is seen here, and in fact at the threshold of 15, there are 199 patients out of the 431 had a low score. The chance of obstructive disease was 7%, whereas those with a higher score increased incrementally based on the score as a continuous variable. I'll now show you the results for each of the patients undergoing this study. And up here we have the patients who had a positive perfusion score based on the core lab read. Here we have a negative perfusion score. And here's the score increasing along this axis. These patients, the open circles, actually represent those who did not have obstructive disease on cath or CTA. We'll overlay this then with those who had obstructive disease. So the patients who had obstructive disease, much more common in the high score area, many of them positive for perfusion imaging, some of them negative. And then if we look at the overlay, that is those patients who, for example, in this quadrant who had a positive nuclear test and a score greater than 15, half of those had obstructive disease, whereas in this category here, this quadrant, those with a negative study, only 3 out of 151 had coronary disease in this group. So the summary statistics are shown here. The sensitivity of the score, substantial at 89%, with the negative predictive value also important at 96%. So a very sensitive test. The core lab MPI, more specific for coronary disease, 90% specificity with a positive predictive value of 41%. So a potential diagnostic algorithm could be, if one thinks of using scores sequentially with perfusion imaging, one could take these 431 patients' performance score. If a score was low, those patients perhaps could need no further testing. Of these, 7 had turned out to have obstructive disease on evaluation. If those patients had a score above 15, however, those patients could go on to perfusion testing, which looks for does the patient have ischemia, not necessarily just anatomy. And if they had a positive MPI, that is ischemia in addition to this positive score, they could go to cath, which would be 8%. And if such a schema was used, about half of these patients then would have coronary disease. Such a schema then would allow a decrease in perfusion imaging of 46% and a 29% decrease in diagnostic caths, and improving the diagnostic yield of cardiac cath. 6-month follow-up, as promised, 97% of patients had follow-up at 6 months. Of those, 25 had early revascularizations within a month. All but one of those patients had a positive score. There was a patient who had a stroke and a patient who had a non-fatal MI and one late revascularization. Each of those had a score that was positive. Logistic regression suggested, as you might expect, the increasing event likelihood based on score. Limitations of the study is that it's an outpatient population, not a particularly sick patient group. This is not a group of patients coming in with positive troponins. These are non-diabetics with the average age of 56, somewhat lower than a typical patient coming in for a nuclear study. We excluded, for example, unstable angina. 77% of the patients were able to exercise. Typically in an outpatient laboratory, it's more like 60%. So again, a less ill group. And the prevalence of disease was 15% in this population. As well, we're testing a score versus obstructive disease, which makes sense. Then we're testing it secondarily against a physiologic test looking for ischemia, which is related but not the same as an anatomic test. In conclusion, the score was an excellent predictor of obstructive disease in patients presenting with chest pain referred for perfusion imaging. Using a pre-specified threshold of 15, sensitivity was 89%, negative predictive value 96%. The score outperformed site read and core lab MPI. Thank you very much.